Hello, this is Kim Jungle. Today's topic is the orthodontic treatment goals. When we are trying to go somewhere, it is important to know where we are now and where we are going. It is the same in orthodontics. It is important to know the current patient's condition and the goal of treatment. Here is Incheon International Airport, here is Seoul, and our dental hospital is here in Bupyeong. If you want to visit our dental hospital, where should you go? Of course you would have to set your destination to Bupyeong before you leave. If you set your destination to Incheon International Airport or Seoul, you would lose your way and waste effort. Now let's think about this in terms of orthodontics. There are various malocclusions such as open bite, deep bite, class 2, class 3, class 1, and midline deviation. Many orthodontists set their treatment goals to Andrew's 6 keys to normal occlusion, and this indeed is correct. However, setting treatment goals like this has a high chance of making errors in diagnosis. Therefore, it is important to know what to think about in diagnosis stage and finishing stage. When orthodontic normal occlusion is achieved after set-in, it can then lead to Andrew's 6 keys to normal occlusion. The first orthodontic treatment goal is to match the upper midline to the facial midline. We mainly focus on overjet and canine and molar keys on side view. But the first thing to look at is whether the upper midline and the facial midline match. In this patient, the lower midline could have deviated to the left, or the upper midline to the right. You have to think about the severity of the upper midline deviation. If it is severe like this, you have to contemplate on it again, because it is very difficult to treat in the finishing stage. In most cases, crowding can cause the midline to deviate to either direction, and the deviated midline should be moved to the opposite direction. We evaluate the upper midline based on midpalatal RAF in model analysis, but there is a limitation. If you look at this patient, it seems like the upper and lower midlines match. But in fact both the midlines are shifted to the right, so they both have to be moved to the left. Upper midline can deviate due to many different reasons. In many cases, a missing lateral incisor on one side causes midline deviation, and also severe crowding can cause the deviation. As you can see, the midline is deviated from the philtrum. If the midline is deviated in an extraction case, you have to think over which tooth to extract. If the second premolar is extracted, the treatment will be difficult. Extraction of the lateral incisor can be effective, but the treatment is not easy. So the first premolar can be extracted. Then we have to approach the treatment strategically. In order to match the upper midline to the facial midline, you can delay the bonding on the right canine and use open coil spring in this space to move the midline, and at the same time close the extraction space on the other side. As you can see, this patient has severe linguversion of upper incisors and a missing left lateral incisor. Due to severe linguversion of upper incisors, I decided not to extract any teeth. but the treatment was unsatisfactory because the upper midline and the facial midline could not be matched. So the right upper first premolar had to be extracted in order to match the upper midline to the facial midline and the lower midline. The upper midline can be evaluated with the philtrum and PA cephalogram. You can see that the patient has the upper midline deviated to the left. After treatment, the midline matches the facial midline and the philtrum, and it is evident in the PA cephalogram as well. The second orthodontic treatment goal is to place the upper incisors in normal angulation and position that satisfy aesthetics. Yuan-to-lip line measurement is important in the position of the upper incisors. The ideal value of plus 3 mm means that the incisal tips of the upper incisors are positioned 3 mm below the lip line. The value over 5 mm means overruption, and less than 2 mm means underruption of the upper incisors. Underrupted upper incisors can be extruded. But if they are overrupted, they must not be extruded even if the malocclusions appear to be similar. Instead, overrupted upper incisors should be intruded. The angulation of the upper incisors can be measured relative to the FH plane or the palatal plane. It is important to remember that yuan to FH is 114 degrees. Yuan to FH of less than 100 degrees means linguversion of the upper incisors, and more than 120 degrees means labioversion. You should also think about the tooth movement pattern in non-extraction and premolar extraction cases. How do the teeth move in non-extraction case? The upper incisors can be proclined during leveling stage. But if class 2 elastics are used, the upper incisors are retroclined while the lower incisors are proclined, and vice versa if class 3 elastics are used. Then how do the teeth move in premolar extraction case? In general, both the upper and lower incisors are retroclined, and the amount of movement varies according to anchorage value. If class 2 elastics are used, the upper incisors would be even more retroclined, and class 3 elastics would cause the lower incisors to be further retroclined. In tooth movement, 1 mm of retraction requires 2.5 degrees of tipping. Then the size of the first premolar of 7.5 mm would convert to 18.75 degrees of tipping. Let's apply this to the angulation of the upper and lower incisors. The ideal value of yuan to FH is 114 degrees. If you add 18.75 degrees, you get 133 degrees, which means the upper incisors should be maximally retracted if yuan to FH is more than 133 degrees. Then how about IMPA? The ideal value is 90 degrees. For the same reason, the lower incisors should be maximally retracted, without protraction of the molars to close the space. If IMPA is more than 109 degrees. This 13.11 years old female patient has anterior open bite and protruded lips. There is a high level of activity of mentalis muscle, meaning that it is difficult for the patient to close lips. But the facial profile is acceptable. ODI 63, APDI 91, CF 154 show that this is a class 3 high-angle case with slight protrusion. FMA 36 to lip line 3.9, UOP 13 and POP 13 are normal. to FH is 121 degrees labioversion because of class 3 skeletal pattern. to MP is 93.7 degrees and is normal, but IIA is 108 degrees, which is a very small value. The third molars can be extracted in this patient. But the problem with the third molar extraction is that facial profile cannot be improved. And here you can see that there is not enough posterior available space. So the posterior movement of the mandibular second molar is limited even if the third molars are extracted. In other words, this approach is not good for aesthetics, and there is a high chance of relapse of anterior open bite. Therefore, many choose to extract the upper second premolars and the lower first premolars because of class 3 skeletal pattern. But the problem here is that the lower incisors are retroclined too much, and the extraction space can be relapsed because of the big size of the mandible. Both non-extraction and extraction are problematic. The patient's to FH is 121 degrees, and 7.2 degrees of change is required in order to achieve the ideal value of 114 degrees. Which means that the upper incisors should be retracted 2.8 mm. So the extraction space should be closed by 2.8 mm of retraction of the incisors and 4.7 mm of protraction of the molars. Is the extraction of the first premolar or the second premolar preferable for this tooth movement? The extraction of the second premolar would be more efficient, and it would be preferred in class 3 skeletal pattern. If the mandibular teeth have to be extracted in class 3 skeletal pattern, I choose the second premolar, and I will discuss about this later. The third orthodontic treatment goal is to make proper overjet and overbite of 3 mm. Many orthodontists choose the position of the lower incisors as reference. In class 2 malocclusion, the lower incisors are proclined, and if the lower incisors are chosen as reference, they have to be retracted. In order to achieve proper overjet, the upper incisors have to be retracted by a large amount, which in turn result in linguversion and extrusion. On the other hand, if the position of the upper incisors is chosen as reference, the upper incisors can be moved to an aesthetic position. The lower incisors can then be slightly proclined in order to make proper overjet and overbite, which means that non-extraction treatment is possible. The fourth orthodontic treatment goal is to keep the upper canine symmetry. The position of the upper canines in relation to the midpalatal raphe was evaluated in model analysis. In many cases, the position of the upper canines and the contact points of the upper first molars are symmetric. But in some cases, the position of the upper canines is asymmetric, while the position of the contact points of the upper first molars are symmetric, and in other cases, the position of the contact points of the upper first molars are asymmetric, while the position of the upper canines is symmetric. The extraction option can vary depending on these circumstances. The fifth orthodontic treatment goal is to make class 1 canine-key relation. After achieving the upper canine symmetry, the lower canines are positioned in front of the upper incisors to make class 1 canine-key. If the upper canine is positioned mesial to the lower canine, the canine key is full class 2. And if the upper canine is positioned right above the lower canine, the canine key is half class 2. On the other hand, if the lower first premolar mesial to the upper canine, the canine key is full class 3. And if the lower premolar is right below the upper canine, the canine key is half class 3. As you can see, the overjet relation is okay despite the class 3 malocclusion. The direction of the treatment can vary depending on the canine key. For the same class 3 malocclusion, satisfactory treatment results can be obtained with the use of MEAW if the canine key is half class 3. But the result may not be satisfactory if the canine key were full class 3. Therefore, it is important to pay attention to not only the incisor overjet but also the canine key. Cases with class 1, half class 3, or half class 2 canine keys can be effectively treated with MEAW. But cases with full class 3 or full class 2 canine keys cannot just be treated with MEAW. Additional appliances or different extraction options are required to make half class 2 or half class 3 canine key. The sixth orthodontic treatment goal is to give retrusive control on premolar area. In other words, the premolar relation has to be properly formed. There will be a detailed lecture on retrusive control later. Retrusive control means that the occlusal contacts in the premolar area prevent the mandibular posterior movement, and as a result position the mandible forward. Therefore, you have to pay attention to the occlusion in premolar area. The buccal cusp of the lower premolar should contact the inner slope of the lingual cusp of the upper premolar. This relationship is important for satisfactory orthodontic treatment. In order to achieve retrusive control, the lingual cusp of the upper premolar should be located at the distal fossa of the lower premolar. Since this can only be seen on lingual side, it is important to think about the direction of tooth movement when looking at the buccal side. The mesial marginal ridge of the upper premolar should make contact with the cusp tip of the lower premolar. Then how should the teeth move in order to form this relationship? The upper dentition should move distally, while the lower dentition should move mesially. Both extraction and non-extraction treatments should be performed accordingly. Now that the occlusal plane is determined, the next orthodontic treatment goal is to upright the lower molars. If the lower third molars interfere with uprighting, they can be extracted. It is important to pay attention to these 7 orthodontic treatment goals in the diagnosis of all the patients. 1. Match the upper midline to the facial midline. 2. Place the upper incisors to normal angulation and position. 3. Make proper overjet and overbite. 4. Keep the upper canine symmetric. 5. Make class 1 canine key relation. 6. Give retrusive control in premolar area. 7. Uprighting of lower molars. Many orthodontists set their treatment goals to Andrew's 6 keys to normal occlusion. Keep in mind the anterior component of force and that teeth slowly move throughout the lifetime. Therefore, the orthodontic normal occlusion achieved by orthodontic treatment will go through the process of settling to accomplish Andrew's 6 keys to normal occlusion. Thank you for your watching.